I want to now ask you, Hossam.
Sure.
You have been practicing for almost a decade in Dubai.
Yes.
What is your most common condition that you treat surgically in this country, in urology?
Well, almost the number one complaint is always stones. There is a high rate of stone formation in the region, in the GCC, and we are not sure whether it's due to dehydration or it's something from the weather or whether it's the type of water. We don't have any solid evidence, but we know that there is a high stone formation in the region. Now, we have been treating patients for the past 10 years, and a lot of them are on medications, a lot of them require some interventions. Yesterday, I had 2 cases. I was on call on duty, and we had 2 cases. One of them, I decided to do a simple intervention. He had a stone in the upper ureter. He presented to the emergency with severe flank pain and blood in urine also. He was panicking. He is visiting the country. He didn't know what hit him. It was the first time for him. So when he came to us, the GP in the emergency did the blood test, urine test, and as we spoke before, he found blood in urine. Then he requested an ultrasound and the stone was found. Then they requested for my help. I checked the patient. He had an upper ureter, quite large stone, and it was obstructing. The pain was persistent. The pain was not going away with intravenous pain medications. So this is when we said, listen, now it's time to do a small intervention. Nothing big, nothing serious. He did have a little bit of elevated blood tests, almost a starting infection. Now at this point, a urine test, even if it shows blood with no white blood cells, we can still not be sure whether there is an infection or not. So I decided to take him to our minor procedure room, do a cystoscopy, place a tube to bypass the stone, and relieve him from pain.
So any patient who comes with very severe stomach pain and nausea and vomiting in this country, one of the commonest conditions we come across are stones.
Yes, correct.
And do all stones need to be treated with some form of intervention?
No, not always. As you said before, the population in UAE is mainly young people, and most of them have small stones, tiny stones that require no intervention. They mainly require good hydration, some medical treatment, and mainly they have to walk, run, jog, and the stones should pass. Now we have criteria for stone size based on a CT scan, which is the most accurate in diagnosing stone size. If the stone is less than 5 millimeter, 4 millimeter, those stones tend to pass spontaneously with medications. The other category of patients with larger stones, or we call them borderline stones, between 5, 6, and up to 8 millimeters. Those are in the gray zone. We are not sure whether they can pass the stones or not, but we always ask the patient if his labs are normal, if he is able to control the pain with pain medications, if he can tolerate it, to try medications. We call it medical expulsion therapy. So we start with the medications and we keep monitoring the patient. It's close monitoring. We provide our mobile phone number or the hospital numbers, and they contact us in case of any emergency. What the patient should be looking for in these cases, if he has fever or severe pain or persistent nausea and vomiting. In those cases, he need to come back to the hospital for a small intervention. If all is normal, the pain is fine, patient has no symptoms, but the stone doesn't pass, we do recommend the patient to come back weekly for a blood test and ultrasound check. Some patients, the stone will sleep in the ureter, it will cause obstruction, he will have no pain, but he cannot keep the stone in the ureter. We usually recommend 1 week visit, then after another week, another visit. And if on the 2nd to 3rd week he doesn't pass the stone, we cannot delay a procedure anymore. We then ask him to go for an intervention. We recommend an intervention. And then we discuss with the patient what type of intervention.
Do you have in Saudi German facilities to treat stones without an operation or a procedure?
Yes, we do. It's Shockwave treatment, or ESWL. So this is a non-invasive procedure. It's done under sedation. So we put the patient on a small table and we target the stone, whether it's in the ureter or in the kidney, with ultrasonic waves to break it down to small pieces for fragmentation. Now, this is a very good procedure, in my opinion. It is non-invasive, so there are minimal risk of complications if done properly, and it's safe. It's a very safe practice, and it's one of the safest and most old practices in urology. The good thing about it, it's, as I said, non-invasive. The downside is that patients should pass their stones on their own after we break it down for them. So people sometimes are confused. They come to us saying, "Doc, we did the Shockwave, but I still have pain. The stones are passing, it's painful." Then I tell them, yes, it is painful. Because Shockwave, I'm not removing the stones, I'm just breaking them down to a smaller size. You have to drink water, take the medications, and it will clear up. But we do have a very nice successful stories. We have done Shockwaves for people starting from age of 5 years all the way to 70 years. And I was amazed by an elder lady in her 72. She refused the ureteroscopy and she went with Shockwave treatment, and it was very successful. The stone was about 30 millimeter. She refused the stent. With simple one Shockwave session, we were able to fragment the stone, and in 1 week she cleared all the stones. And there is another also very nice successful story. A retired physician, he was a pediatric physician, also with a huge stone about 50 millimeters. He knows exactly what is ureteroscopy, what is Shockwave. He said, "No, I don't want any ureteroscopy, I want Shockwave." Also, one session he cleared all the stones on his own within 1 week. So we have very nice successful stories with Shockwave. But still, Shockwave is not for everyone. We still have our criteria in selecting patients.
Like it cannot be done in pregnant women. It is
Of course.
still not proven to be
Yes.
safe in pregnancy.
Yes, because I'm not going to put a pregnant lady under sedation and do Shockwaves because we don't know what's the effect on the baby. And even for young ladies, if the stone in the distal ureter, I prefer to avoid Shockwave because it is not known to us what is the effect on the ovaries. So I prefer to avoid Shockwaves in ladies who are young in lower ureter stones, and in pregnant ladies.
In the olden days, we had to make big cuts to remove stones from the urinary tract, and the patient would take months to get better with an ugly scar. And when was the last time you had to do something like that for a patient?
That was 10 years back. So we are lucky to be in UAE. We are lucky to be in this country, which has a very good medical facilities. We have state-of-the-art instruments, ureteroscopies, shockwaves, which is not available for all other countries. In many other countries, they don't have these instrumentation that we have, this luxury that we have. So yes, I'm Syrian, and the last time I had such surgery was in Syria, maybe 12 years back, where we had to remove stones. Until now, big stones are removed with surgical instrumentation. Here we have PCNL, we have high definition cameras, ultra high definition cameras, the tiniest scopes that can reach anywhere. Hopefully this technology will reach everywhere soon, in all countries will be available for all patients.
Can you tell me a little bit, you said PCNL. What does it mean? What do you do when you do PCNL?
PCNL is the most advanced in treating stones for now. It's short for percutaneous needle lithotripsy. It is done under full anesthesia, a tiny incision done on the flank to target the stone with direct scope through the skin. It's not through the normal opening. It's done through a small keyhole skin incision. The scope will go directly through the kidney tissue to the stone. It is mainly for stones that are big in size that cannot be cleared with shockwave or ureteroscopy, flexible ureteroscopies. So those stones cannot be cleared through the ureter. So for example, if a patient has a 25 millimeter stone in the kidney, so a simple session of shockwave will generate too many small stones that the patient will be having terrible pain, and he will have a lot of stones in the ureter that will block the way, and he will not pass the stones. So stone clearance in such cases are low. In these cases, we avoid the ureter. We place a tube, a large tube, through the skin to the kidney. We do the treatment. We break the stone to small pieces, and through that tube, we can remove the stones. It's like with a suction mechanism.
Okay. So one procedure we discussed is PCNL. What is ureteroscopy and flexible ureteroscopy and laser, all these terminologies that are used nowadays in urology?
Yes. People mistaken our shockwave for laser. The shockwave that we are talking about now, the ESWL, is ultrasonic waves. We break the stone from outside with ultrasonic waves. It's mainly a very powerful ultrasound machine that generates high velocity and high energy sonic waves to break the stone. The laser used mainly in ureteroscopies. When we pass a tiny camera through the urethra, we see the stone, and then we pass a tiny laser fiber, and the laser has to be in direct contact with the stone. So the difference between the laser and ultrasound is that the laser has to be in direct contact with the stone when the shock wave is through the skin. So the ultrasonic wave can swim or can just go through the tissue to reach maximum concentration of the stone, break it down. So ureteroscopy has been in urology for the past maybe 15 years or maybe more or less. The laser keeps evolving. The current laser is magnificent, of course. We pass a tiny laser fiber through our small scope to the stone site. We put it in direct contact with the stone and we vaporize it mainly. So it generates laser to vaporize the stone and make it fragments or to dust it. As we spoke, we have a rigid ureteroscope and a flexible ureteroscope. The difference is that in rigid ureteroscope, we deal with ureteral stones, mainly in the middle and lower third of the ureter. Well, my personal preference when I go up in the ureter, I don't like to use the rigid scope. There are other physicians that will still do ureteroscopies with the rigid scope in the upper stones. But I don't prefer to cross the second third of the ureter to the upper third with a rigid. I prefer to do any procedure up with a flexible scope. The flexible is flexible. It can maneuver easily in the upper ureter and in the kidney. So we can go in any calyceal system, in any area of the kidney with the flexible scope, target any stone anywhere, catch it and take it out after we fragment it to small pieces.
So what is the advantage of flexible ureteroscopy over this PCNL procedure which you discussed?
All urology procedures for stones, they complete each other. I wouldn't say there is one better than the other. I would say they complete each other. PCNL is good that we avoid the ureter. We go through the kidney. So this is plus. The minus is we have to do a small puncture through the kidney, which has higher risk of bleeding or post-operative bleeding. While ureteroscopy, we have to go through the ureter. There is no incisions. It's minimal invasive. But we have risks also, like there is a risk of ureteral injury and post-operative ureteral stricture. That's also a possibility. So again, they complete each other. With the nephroscope that goes through the skin, the PCNL, we can deal with bigger stones, staghorn stones. While with the flexible, we mainly deal with 15 to 20 millimeter stones.
So once you have cleared a patient of stones, you have treated him successfully, doesn't have any stones, does he have a chance of getting stones again? And what advice would you give a patient who has been treated successfully for stones?
A very good question. When we finish with our ureteroscope or whether PCNL or Shockwave, it depends, we take a stone sample for analysis. We have made a practice in our hospital to take a stone for analysis, send it to laboratory, and the lab will check what is the stone composition. And then we can tell the patient what's the risk. And there are many types of stones, whether it's uric acid stone, calcium stone, and other types of stones. Then we tell him in general, this is my own practice, that you are prone for this or that type of stone. Now, if a patient has a family history of stones, his father has stones, his uncle had stones, then he's at high risk of forming the same stones over and over. In these cases, I prefer to send the patient to our colleagues in nephrology for further investigation to see what type of metabolic disorder he has. Our body and our kidneys deal with a lot of electrolytes, calcium, potassium, sodium. The stone can from any of these electrolytes. So I don't dig deep in details. I refer to my colleague who will do proper investigations. In stone formation, many organs could be involved, like the parathyroid, the thyroid, vitamin D deficiency. All these are risk factors of forming stones. Our food, our diet, intestines also involved in stone formation, all that together. It has to be measured, calculated by our colleagues, and they will tell the patient whether it's more of diet advised to follow or to increase water intake or to avoid specific foods, or whether he need like further treatment with some medications to prevent, or to, at least not to prevent, but to minimize the risk of stone formation. So if a patient is having, for example, once every 6 months a recurrent stone formation, he will be having once every 2 to 3 years. Now, we cannot guarantee for our patients that we will not have stone at all, but we will minimize the risks.
Suppose a patient, you have treated him for stone and he doesn't have any complaints after that for 6 months or 8 months. Do you still advise them to be on follow-up?
Yes, at least once a year. Minimum is once a year. If he has higher risk factors, I would tell him every 3 months, 6 months, we can schedule an appointment for him based on his history.
Now, UAE is predominantly a Muslim country, and we are approaching Ramadan now.
Yes.
Now, Ramadan, in my short experience in the UAE, is a time when we see a lot of stone patients. Any advice you have, and any reason for, what advice will you give to people during Ramadan to reduce their risk of forming stones?
Another very good question from you, doctor. Thank you. So during the holy month, I would tell my patients, especially that who come back with regular stone formation, I cannot prevent them from fasting. I'm not in a position to do that, but I can tell him, if you're going to fast, please drink. Make sure you have enough water intake and fluid intake, especially after suhoor. Before suhoor. Try to drink as much as you can. Try to avoid dehydration. But if a person is like a certain age with many risk factors, I would advise him not to fast. It depends on his situation. Those category of patients are mainly our nephrology clinic patients. So in such cases, they will be handled a small brochure about what to do, what to avoid, how to drink. But yes, people will eventually, most of them will still fast, and many of them will have stones by the 15th, 20th of Ramadan. So at the first couple of weeks, all is fine, but towards the end of Ramadan, yes, we will be seeing them with stone formation. Hopefully they will not come to see us. Hopefully they will be fine, but I would recommend before the holy month, if they can all come and double check. If any patient who has stone formation, better to have his kidneys checked before the holy month.
Anything about the diet during Ramadan that can be adjusted for stone patients?
I would say it depends. If those patients have high uric acid and they have tendency to uric acid stones, to cut down on the beef, the red beef and beans. If those are calcium stone patients, to watch their diet from milk and milk products. And if those patients are having oxalate stones or oxalate component in the stones, to check what they're eating from the cashews, from the vegetables also. So it depends on their diet. It depends on their stone. Then we can advise the diet. But mainly all of them should be well hydrated after they break their fasting.